invite you to your next presentation, which is approach to the management of ankylosing spondylitis. Please, sir.
I've been very careful, so I've rephrased it as medical management of ankylosing spondylitis. So the first one is, the first question that I ask, so this is something that I do in every patient, so I'm just giving you the approach that I use, so it will be very practical, very clinical. So when the patient comes to me, is the patient having active disease of ankylosing or not? If somebody has had a 20-25 year ankylosing, he's stiff all over, but is not complaining of any pain or morning stiffness, the disease is inactive and you don't have to be too intrusive with your medications at that time. Presence of inactivity of morning stiffness of more than 35-40 minutes, improving with mobility, inflammatory markers. In contradistinction to rheumatoid, somehow in ankylosing, the inflammatory markers does not seem to mirror the disease activity. So you have to be a little careful in analyzing them. And presence of synovitis, enthesitis or bone marrow edema. This is very important. MRI has been a brilliant tool. When the early disease is there, all of us pick up. But somebody with a long-standing angst has come with an increased back pain, it's better to do an MRI and find out whether there is any inflammation there or not, or is there something else that's causing the back pain, which is important to find out. So what is this is very, very important. The pathology in spondyloarthropathies, including angst is, it can be enthesitis, it can be synovitis, or it can be non-infectious inflammatory bone edema. And you can have various combinations of all three in that particular patient. This is very important to know because the kind of drugs that you will use depends on this. Otherwise, the patient will not improve. So I'll tell you what I mean. This is an ankle X-ray of one of our staff in Hinduja who has angst. He came with an ankle pain, and as you can see, I don't know whether my pointer, can see my pointer? Yeah. He has enthesitis, where the Achilles tendonitis has come and joined here. He has synovitis as well, but he also has, the calcaneum has an inflammatory bone edema. So this man had all three pathologies that I spoke about, which is very, very important to find out and then go ahead with the treatment. So this is a nice, simple tabular column which tells you the drugs and how they act on these 3 or 4 things that we spoke about. As you can see, peripheral arthritis, you go above down, NSAIDs are good, no doubt about it. DMARDs, which are often used in rheumatoid arthritis, are very useful for peripheral arthritis. DMARDs are not that good when there is enthesitis or only sacroiliitis or only, dactylitis. You have to be very careful. JAK2 inhibitors which have come, the tofacitinib has been found to be very good for peripheral arthritis and biologics when you go above down there. Axial disease, NSAIDs are good, and you find that the DMARDs, although salazopyrin is being used, and there are some studies on salazopyrin, the clinical experience has been, it has not been as good as it would, as we probably see in rheumatoid arthritis or something. The back pain doesn't go away even after 6 months, 9 months of salazopyrin. It does not act that well. JAK2 inhibitors are also good. Biologics are very, very good for the axial disease, somebody who has only a spine. Dactylitis is a combination of synovitis, tenosynovitis, and periostitis. All 3 are there. So that's why the whole finger is swollen, and even the inter-joint bone, if you try and palpate, it will be very tender. That's because of the periostitis that the patient has. So all 3 pathologies are there, and there you find, again, NSAIDs are good. DMARDs and JAK2 inhibitors are okay. DMARDs especially are not that good, but biologics again come good there. Enthesitis, again, you see that NSAIDs and biologics are good, the other 2 are not good. So therefore, in your patient, what pathology is going on is something that you need to know, and in this clinical examination and sometimes imaging tells us what is going on, and then we can plan the treatment. NSAIDs, again, usually young patients, these are ankylosing in contradistinction to rheumatoid, starts in the second decade of life, 20s. So that's when they have it. So therefore, NSAIDs are more freely used in this subgroup than in rheumatoid arthritis. Axial, important thing to know is that when there is a flare of an like a sacroiliitis, it takes 4 to 6 weeks for it to go, not just 10 days. So you need to continue whatever NSAIDs is working over a period of time and taper it out. Otherwise, what will happen is he will take it for 10 days, again repeat it 1 week later, again repeat it 1 week later. And what can be controlled in 4 weeks will take 4 months. And that 4 months, the inflammation has gone on without getting controlled, and the stiffness has started, which cannot be reversed. So that's the most important thing. So give it for a proper period of time and ask him to quickly go into physiotherapy so that he maintains his spinal mobility. At least try NSAIDs for 2 months before saying that they don't work. Long-acting NSAIDs again, because night-time and early morning stiffness are big problems with ankylosing, we use long-acting ones. And analgesics are added to NSAIDs for better pain control. Steroids. See, steroids are less useful as a whole, rightly said by Sunil, in spondyloarthropathies than rheumatoid. The reason for that is, like I said, in rheumatoid, the pathology is only synovitis. Whereas in ankylosing, I told you there can be 3 different pathologies. You can have a synovitis, you can have an enthesitis, you can have bone marrow edema. Steroids are not good for enthesitis and bone marrow edema. So therefore, it may work, it may not work. NSAIDs work better. That's why we try and avoid steroids. But sometimes, some synovial joints typically are involved in ankylosing, like the C1, C2. C1, C2 can also be involved in ankylosing as much as rheumatoid. And the imaging will pick it up. You will get a panus there, all the changes, plus you will also get enthesial changes in where the alar ligament gets attached to C1, that area. So all that you can see on an MRI. And if synovitis is there, then these are the ones in whom steroid and even disease-modifying agents like. Similarly, in sternoclavicular, sternocostal and acromioclavicular joint, partly is synovial. So therefore, you can try steroids. Not that they will work, but it's a good thing to try because they're cheap. And if steroids work, then adding a disease-modifying agent like methotrexate will work. So it's a good thing to try if you have these. Local intra-articular injections are effective, but be careful about enthesial injections. The Achilles tendonitis, plantar fasciitis, you have to be good at it, otherwise you will put it into the substance or it will rupture. We have had a few patients with that, so be a bit careful with that. DMARDs, only when there is peripheral arthritis, definitely. If an ankle spondyl has a knee swelling, ankle swelling, we'll use it. Also used in axial disease, but it's not, effect cannot be guaranteed like we guaranteed it in rheumatoid. We cannot guarantee only when the spine is involved. So I personally don't use much of disease-modifying agents when only the spine is involved. I don't do it. DMARDs can also be tried when there is atlantoaxial, acromioclavicular, sternoclavicular. Here it tends to use because they are synovial joints. And all 3 disease-modifying agents which are used in rheumatoid commonly, the conventional ones, can be used. Tofacitinib is recently approved and helped our patients with spine and peripheral arthritis as well. It also acts on all 3 pathologies that we are talking about, and I've spoken about the hepatitis B, hepatitis C needs to be done. Thrombosis is something we have to keep in mind. That's the 2-3 main things. And biologics, usually used when C-DMARDs are ineffective or produce side effects or NSAIDs don't work. They are usually added to NSAIDs. Most are parenteral, most are expensive. The last line are all available in India. So you have to choose the one which gives benefit and it's reasonably cheap. We have found over the last few years adalimumab to be reasonably cheap because it can be given only twice a month, and if the patient is better, you can increase the interval of doses from 2 weekly to 3 weekly to 4 weekly and still maintain its efficacy. So that's what we have been doing. As anything in India, jugaad is important. And always look out for other causes of pain. Somebody who does not have an inflammatory back, look out for vitamin D, Anderson's lesions, fractures, because Angst-Pond is an osteoporotic condition. It looks stiff, but it's weak. So they do have fractures, infections, because they're using disease-modifying drugs and immunosuppressants, lack of sleep, lack of exercises and depression. All this can be contributing to the pain. So you have to assess your patient before changing. So majority do well with NSAIDs, but must be persisted for 4 to 6 weeks. If resistant, find out what the dominant pathology the patient has. Synovitis, enthesitis, bone marrow edema, and then plan your therapy. Disease-modifying agents can all be used when there is peripheral arthritis, but may take longer and need higher doses than in rheumatoid. Tofacitinib is a new kid in the block which we are using, and biologics for resistant disease. Thank you all for the patient.